Hello, everybody, and welcome to our special populations webinar series. We're very fortunate this week to have two experts on a very important issue that I'm not sure who that was, but Rusty Reeves, our old colleague Rusty, longstanding colleague Rusty, is the director of psychiatry for Rutgers University Correctional Healthcare. UCSHC provides the medical and mental health care to inmates served by the New Jersey Department of Corrections. UCHC is a leader in the provision of MAT, medication-assisted treatment for people with opioid use disorder, and has partnered with UBHC in creating an innovative peer support program for these persons upon release. Dr. Reeves is a professor in the Department of Psychiatry at Robert Wood Johnson Medical School and the creator and training director of the Department's Forensic Psychiatry Fellowship. He's authored numerous peer-reviewed publications on topics in correctional psychiatry. Peter Treitler is research specialist at the Center for Health Services Research and a doctoral candidate in the School of Social Work. He's a member of the Justice Community Opioid Innovation Network, JCOIN, which is convened by NIDA to provide training and mentorship to early career investigators working at the intersection of criminal justice and substance use treatment. He's currently the project director for the evaluation of the Intensive Recovery Treatment Support, IRTS program, which you'll hear about, a team-based peer support service that provides care coordination, recovery support, and other services to prisoners for up to 6 months before and 12 months after release. His expertise is supplemented by 5 years of clinical practice as a substance abuse and mental health clinician working with justice-involved populations. So, Rusty, I think you're first. Take it away.
Actually, I'll take it first, Steve. Thank you for that.
Okay.
Thanks for that introduction. And welcome, everyone. Thanks for joining us today. So Rusty and I are here today to talk about some of our research on substance use disorder interventions for people who have criminal justice involvement, and specifically people leaving New Jersey state prisons. So Steve, can you see my my PowerPoint?
Sorry, I'm on mute, but I see the slides, yes.
Great. Okay, so just by way of an agenda, I'm going to start with some background material just to kind of talk about the prevalence of substance use disorders in justice-involved populations. And then Dr. Reeves is going to present some preliminary findings from a performance improvement project that he did, looking at engagement in substance use disorder treatment after prison release. And then I'll share some findings from a qualitative study that we're doing that's on the experiences and needs of released prisoners with substance use disorders. And then finally, I'll talk a little bit about some of our next steps and work that's in progress that's really designed to extend some of what we're going to be talking about today. So just to begin with, most of you probably know that substance use disorders are very common in justice-involved populations and much higher than in the general population. So about 58% of state prisoners meet diagnostic criteria for substance use disorder nationally, and around 15 to 20% of state prisoners reported regular use of heroin or other opioids before incarceration. According to the National Survey on Drug Use and Health, about 43% of individuals with a heroin use disorder reported some kind of past year criminal justice involvement. And people being released from prison are at a very high risk of overdose mortality and other adverse health outcomes. So to kind of illustrate that, this figure is from a kind of a landmark Washington state study that looked at post-release mortality after prison release, and it shows the very high risk of death after prison release. So here the horizontal dashed line represents the adjusted rate of mortality for all Washington residents, which is around 223 per 100,000 person years. And then the solid bars show the mortality rates among people released from prison at different periods of time. And so Overall, after prison release, there are 777 deaths per 100,000 person years, about 3 times the general population rate. And that risk is especially high in the first 2 weeks of release, and that's shown by this bar here. So 2,589 deaths per 100,000 person years. And when you break this down further, as they did in this study by cause of death, the risk is especially high for drug overdose, which is also the most common cause of death after prison release. And people in their first 2 weeks after prison release have 129 times risk of death from drug overdose than the general population. And so that kind of speaks to the need for interventions that safely return people with opioid use disorder to the community. And almost everyone who is incarcerated will eventually come home. So it's really important to provide provide care in prisons, and then also make sure that that care can continue in the community. And so many prisons offer substance use disorder treatment, but at a national level, behavioral treatments are much more common. And actually, nationally, most prisoners don't receive any treatment. Although in New Jersey, there's been a lot of effort to make sure that treatment is available for people who want and need it. And when it comes to opioid use disorder specifically, the most effective treatment, there's a lot of research showing this, is medication, which uses 3 FDA-approved medications: methadone, buprenorphine, and naltrexone, each of which has its own strengths and drawbacks. Methadone is highly effective. It's a full opioid agonist, but one of the downsides is that it requires daily attendance at a methadone clinic for dispensing, which many perceive as burdensome. Buprenorphine is a partial agonist, which is also very effective in reducing cravings and preventing withdrawal, but it can be prescribed by any physician that has the appropriate waiver from the DEA, and so there's much lower access barriers. You can get a prescription for it like most other medications. And the third option is naltrexone, which is an opioid antagonist, and it prevents opioids of abuse from blocking to opioid receptors, and so it kind of works for relapse prevention. But it works less effectively in reducing cravings and addressing the reinforcing effects of opioids. So retention on that medication is not particularly great. So even though medications are shown to be the most effective treatment modality for OUD, they're very underutilized, especially in the criminal justice system. But that is actually changing quite rapidly. States are expanding their use of MOUD because of the ongoing opioid crisis, and also ethical issues. There's been some kind of increasing arguments made that correctional systems have an ethical duty to provide the evidence-based medication. So it's possible that in the next couple of years, it may be required that correctional systems offer this type of care. But just to kind of give you a state of where, an overview of where things are at today, this is a chart from the National Academy for State Health Policy, which shows the availability of MOUD in state prisons. And so a lot of states still don't offer any medications, and those are the ones shown in gray. And a substantial number only offer naltrexone, which is the one with the least successful outcomes. And then 9 states offer all 3 medications, and one of these is New Jersey. And so we'll get to this in a minute, but New Jersey is one of the early implementers of prison-wide MOUD, and that's largely due to the efforts of Dr. Reeves. And it's also a reason why New Jersey is an ideal setting to study the uptake and outcomes of prison-initiated MAT. I won't get too much into it, but here's a bit of a literature review of the effectiveness of pre-release of medication for opioid use disorder initiated before release from prison. There's a good deal of evidence showing that initiating MOUD before release increases post-release treatment engagement. So people are more likely to attend their first appointment after release in general. The research is a little bit less conclusive when it comes to other outcomes of pre-release medication for opioid use disorder, such as overdose, and hospital use. And that's something that we're really trying to get at in our research, and what we'll talk about towards the end of this presentation. But some studies do show that it reduces drug use after release, especially in the immediate post-release period, but those effects seem to diminish or disappear with longer-term follow-up times. But again, there haven't been a ton of studies on this topic, and there haven't been studies with like larger usual care populations. And so that's something we're pursuing. Did want to point out one study which was done in Rhode Island, which implemented similar to New Jersey, it implemented a statewide prison MOUD program in 2017. And they found that after the implementation of that program, mortality among recently released individuals decreased by 60%. So if you do the math, in 2016, 26 over 179 people who died of an overdose had recently been incarcerated, and that went down to 9 of 157. And so it went essentially from, so in 2016, a full 15% of people who overdosed in Rhode Island had recent history of incarceration, which is a huge number. But then that went down to about 5.7% in the year after they implemented this prison-wide MOUD program. One of the challenges with addressing substance use disorders in this population is the transition of care from prison to the community. A lot of people are stable on treatment in prison, but then they're kind of lost in the transition. And that's not only true for substance use disorders, but all types of healthcare. And a PI project, a performance improvement study that Rusty did here in New Jersey, found that only 22% of initial aftercare appointments were kept by recently released inmates. And there's some evidence that patient navigation might increase. It might help with that transition by helping people get into care and stay in care. But the findings are really mixed. There's been a couple of trials that have included a patient navigation component, like this Farabee and the Schwartz study, that found no effects. There was an earlier study by Binswanger that did find that it helped people get into and stay in treatment. But it's an area that's where there's a lot of research happening, and it depends a lot on program structure. And so peer navigation or health navigation is a promising approach. It doesn't yet have extremely rigorous evidence in support of it. And that's, again, something that we're looking into and we'll be talking about today. All right. And so before I turn it over to Rusty, a bit more background on what New Jersey has done to address this problem and help people with substance use disorders leaving the prison system. And one thing is the implementation of this system-wide MOUD program. And like I said, New Jersey was one of the earliest implementers of this, starting in 2016 with naltrexone, and then expanding, making buprenorphine or Suboxone available to people in 2017, and then further extending the program to make methadone maintenance available, which was previously available for pregnant inmates, but it was expanded to a larger population in 2019. And to date, I think it's actually at this point well over 3,000 people have been prescribed MOUD while incarcerated, and primarily that's been buprenorphine. The other major thing that New Jersey has done is implemented the IRTS Peer Navigator program, and that's operated by University of Behavioral Healthcare. It's the Intensive Recovery Treatment Support Program, which was implemented in 2018 and has so far, through the end of last year, it served over 1,600 people. It's a collaboration among the Department of Corrections, Department of Human Services, and University of Behavioral Healthcare. And essentially this provides team-based peer support, care coordination, and other services to prisoners with opioid use disorder for up to 6 months before and 12 months after release. It's a wraparound kind of intensive program where the core staff members are peer navigators, people with shared lived experience, so typically either with substance use disorders or incarceration or both. But they're also supported by a much broader team that includes doctors, nurses, case managers, and so on, so that to the extent possible, they can help people, help link people to care, provide just kind of emotional support. That's the main thing that the peers do, but also help them address other psychosocial needs and things that could get in the way of recovery. So with that, I'll turn it over to you, Rusty.
Okay, thank you, Peter. Peter, just can you hear me?
I can hear you, yeah.
Well, I assume everybody else can too. Good. So I figured out the mute button. Welcome everybody who's interested in learning about MAT and corrections. I enjoy giving this talk because it's promising, the results we see. And then after I finish here, Peter will go on with how this is leading to a more extensive study that Dr. Crystal and Peter and I and others are working on. I should let everybody know that if you can see the background here, Peter has the sophistication to blur his prosaic background. I don't. I want to let people know that at this stage, if you go as far as I do in a successful career, you too can have a filing cabinet in your own office in a prison one day and be grateful. So there we go. This is what y'all have to look forward to. All right. Peter, can you hit the next slide, please? Okay. So this PI project was motivated because, as Peter said before, when we were first providing referrals for treatment through the UBHC's interim management entity, the IME, that's to licensed programs. And this is just as we were getting going, and there was no IRTs, and there was very little MAT going on. We found that only 22% of persons that were referred for treatment followed up. And that's a dismal rate of follow-up, even among substance abusers. We thought we could do better. And thus, that was part of the motivation, not just for me, but for people above my pay grade that realized that we need to try something else to try to get people to their appointments. And thus the IRTS program, the Intensive Recovery Treatment Support Program, was created through the state and the DOC and UBHC, and it's still in place and working to this day. We wanted to determine whether the IRTS participation for inmates with opioid use disorder was associated with an improvement of the first substance use disorder treatment appointments in the community. And similarly, we wanted to learn if medications for opioid use disorder for these same inmates, when the MAT was begun in treatment in prison before release, whether it likewise was associated with attendance of first substance use disorder appointments post-release. So this was a PI project. I've since and it was done a couple years ago. COVID has sort of messed up my writing of it, but it's been approved by the IRB to publish. It does have their permission to move forward with this. And like I said, this is sort of some of the inspiration for a better study that Dr. Crystal and Peter are doing to look at the more profoundly and more broadly the effects of treatment services for released inmates with opioid use disorder. Okay, so briefly, medical and mental health care is provided to the inmates within the New Jersey Department of Corrections by Rutgers University Correctional Health Care, UCHC for short. We've been in business since 2005, which anybody who knows this sort of business, for any one entity to have a contract like this with the correctional department, it's an unusually long period of time, and I'm proud of everybody's accomplishment who works within the system to make this happen. Appointments for licensed substance use disorder aftercare treatment paid for by Medicaid. Now, remember, part of this, it's not just UCHC and Rusty Reeves saying, oh, we're going to make this happen. The success to any of this is dependent upon people having insurance to pay for medications when they leave. So Obamacare is part of this too. If Medicaid wasn't paying for this, then there would be no point really in doing this, because the people couldn't afford their meds. So we have Medicaid paying for the large majority of these people. And there's some people with private insurance, but very, very few. Appointments are made by two groups. UBHC's interim management entity, the IME, and they are required by contract to provide referrals to licensed substance opioid treatment programs. So that's important to understand because it has, I think, an effect with the results. Their contract requires them to make those referrals to those programs. The IRTS program, the Peer Navigator program, also makes referrals for follow-up treatment, and they are not limited to licensed programs. So, for example, they can make a referral to a private practitioner who prescribes buprenorphine, and that's it, if that's what the patient so desires. So we have these two UBHC entities providing appointments. And then the IME has, in order for us to have the results that we had, the IME provided the quality improvement data to us regarding the first substance abuse appointment follow-up. Next, Peter. For the methods, we tracked attendance of first appointments by released inmates with opioid use disorder between March and December 2018. Again, the data was provided by the IME. We compared inmates who participated in the IRTS Peer Navigator program with those who declined voluntary participation in the IRTS program and wanted only an appointment. So remember, this is important too in the results. The IRTS program is voluntary. It's not mandated. It was we didn't study parolees because parolees were not, the IME did not make appointments for parolees. So folks who participated in this PI project were people who volunteered to participate in IRTS. They weren't mandated. And likewise, they could choose not to participate. We'd still make appointments for them. Okay, we noted whether inmates were released on buprenorphine, naloxone, which brand name Suboxone, extended release naltrexone, brand name Vivitrol, or neither. Okay, we move on. Okay, here's the overall results. And the sample size is small, but I draw your attention to the left side columns where it says no IRTS total and IRTS total. Let's look at those two columns. So of the released inmate patients who declined participation in IRTS, and they were offered participation, only 30% of those folks showed for their first substance abuse disorder treatment appointment in the community. And if you go the following columns to the right, it really didn't make much of a difference whether they were on medication or not. I mean, again, very small numbers, but medication in that case really didn't make any difference. So 30% if they chose not to participate in IRTS. Again, voluntary refusal of participation. We go down to the next group where we see the IRTS total to compare with no IRTS. And so the IRTS is the Peer Navigator program. Those people who chose to participate, 52% of them attended their first substance use disorder treatment. So that's 30% versus 52%. Now we go to the middle column there and we look at if they're not IRTS and they were on any MAT, 31% attendance of first appointment. But if you look, if they were in IRTS and on any MAT, it was 68%. So with this, I consulted Dr. Mike Guerra, who's recently retired. He's the Department of Psychiatry statistician at Robert Wood. And we go to the next slide. And he suggested that we do an odds ratio to look at the main effects of the Peer Navigator program on attendance and separately any MAT as a main effect for attendance of first appointments. And so here's the results we have. Again, the main effect of IRTS was statistically significant, and I would say also clinically significant, of 52% attendance versus 30% attendance. You see the odds ratio there in the confidence interval. So that's statistically significant. Similarly, but to a slightly lesser effect, any MAT had a main effect also in attendance of first substance use disorder treatment. So 49% of those on any MAT versus 35% of those who were not on MAT attended their first appointment. And that was statistically significant as well. And then in the third box down there at the bottom, you can see their additive effect when we looked at the combination of persons who were in the peer navigator program and those on any MAT, whether buprenorphine or naltrexone. 68% of those people attended their first substance use disorder appointment. So, that's starting to get in the realm where just I as a doctor, making these first, I appreciate seeing that. We're getting well over 50% of people going to their first appointment. And so that was impressive that combination of those two main effects resulted in that first follow-up rate. Now, interestingly, as I was doing this, and I was speaking with the folks in the IME and the IRTS, Micah Hillis and others, and learning about what the contractual limits were for the IME and making their appointments. They had to make them to these licensed programs, which provided not only medication, but also required people to participate in other sorts of groups and psychosocial, psychotherapeutic programming, essentially talk counseling. And we found, and this wasn't the primary intent of the PI project, but what we found, interestingly, again, small sample size, if you look here at the licensed facility, in other words, these were appointments made by the IME, 40% of the persons who had appointments made by the IME attended their first appointment. And if you look at below that, if the appointment was made by the peer navigator IRTS program, 74% of people attended their first appointment. And move to the right a little bit, when the IME made the appointment and somebody was on any MAT, as we said, as we've shown, the attendance went up to 59%. They're on MAT, which has an effect. But even more so when the appointment was made by IRTS and they were on any MAT, 88% of that small, very, very tiny sample size attended their first appointment. And that was tantalizing because to me, it suggests, at least in hindsight, what's obvious in hindsight is that perhaps there's some effect of fitness of appointment to what the person wants. That IRTS, not necessarily by any superiority of the people, maybe that's it, but I think it just has to do with IRTS has the freedom. They're not contractually bound to make an appointment at a certain place. So these appointments that I was learning that they can make, oftentimes just a simple buprenorphine provider without the accompanying components of a licensed program. Also, I think perhaps because it wasn't a licensed program, they could make appointments that were more convenient to people, closer perhaps sooner. I'm not sure. That's just speculation. And that may explain the greater attendance. So, we all want convenience, and it's no different if you're a substance abuser or not. Everybody wants convenience nowadays. We expect it. We want to go something right now, when we want it, where we want it. And so this is not particularly surprising in hindsight, at least. We move to the next one. So discussion, to sum up. Peer navigators and MAT, medication-assisted treatment, were each independently associated with greater attendance of first community substance appointments among released inmates with opioid use disorder. Those are the main effect. The capacity to make the type of appointment that fits the patient's preference may improve attendance of appointments. That was suggested. in our data. Limitations are obvious of this PI project. I mean, just obvious. It's not a randomized controlled trial. Inmates who chose peer support may have been more motivated, and I assume they are more motivated to choose to have somebody supporting you. It's showing you're taking things seriously, and you recognize your risk when you go out there. As you're seeing, Peter showed with the Binswanger study, the risk of overdose is just huge in the first 2 weeks when people leave. Another limitation is the obvious small sample size that we have in this, but that small sample size is the motivation for the subsequent study we're doing. These attendance results are welcome. They're pointing in the right direction and may predict lower overdose risk immediately after release. Again, that's may, we don't know that. That's what we'll find out. However, the results may have little bearing on opioid use and crime 1 year later. Why do I say that? Well, if you look at the literature, particularly the Gordon studies, Kinloch Schwartz out of the Friends Institute down there in Maryland, and other literature as well. And if you know anything about the long literature on methadone, this idea of it being a disease, a recurrent chronic illness, that's what it is. And so as you go further down the road, the results may trail off as people, let's say, stop their buprenorphine. I liken it somewhat similar to people, schizophrenic persons on antipsychotics. Many of them do great when they're on their antipsychotic medication. They feel good and they come back and they say, hey, Dr. Reeves, I'm feeling great. I stopped my medication. And you're going, oh no, not good. And I think maybe that's what happens here with some of these studies that show down the road when people back to treatment for whatever reason. Again, that's my speculation. Move on to the next. Okay, Peter.
All right, well, thank you, Rusty. that was really interesting. And even though it is kind of preliminary with the methodology and everything, it's good to see that that things are, looking promising, and that potentially interventions like peer support and pre-release MOUD can make a difference. And so I'll talk a little bit. Rusty alluded to it a bit, but I'll talk after this section about ways that we're expanding that with a much larger sample size and using methodology that can hopefully control for some of the confounding that Rusty talked about. But before that, I'm just going to talk briefly about some other related work that I've been doing here with some of my colleagues at the Center for Health Services Research. This is a qualitative study, and essentially we started a project not too long ago that's looking at the impact of New Jersey's early prison release legislation. And for those of you who aren't familiar with that, in November of this year, legislation was passed that allowed people meeting certain criteria to have their prison sentence reduced by up to 8 months. And so about 2,000 people were released on a single day back in November 4th. And then since then, several hundred more have been released as they reach that point where they're eligible. But the broader study is really to determine the impact of that large-scale release, 2001 day, on the service system for people undergoing reentry, and specifically on people who have substance use disorders, who have a lot of needs. But in the course of this work, we've also learned a lot about individuals' experiences with MOUD while incarcerated, and then just more generally some of their ongoing needs and challenges as they transition from the prison to the community, which we hope can help us better understand what people's needs are and inform the services that they get before and after incarceration. So this study is in progress, but to this point we've completed 18 in-depth interviews. They're about an hour long each, with people who were released early due to this legislation and who have substance use disorders. And most of them were also on the prison MOUD program while they were incarcerated. And they were recruited with the help of the Volunteers of America, which is a reentry organization that operates in the southern part of New Jersey. So I'm just going to highlight a couple of the themes. Like I said, the study is a bit broader than what I'm going to talk about. It has a lot to do with this early release legislation. But in the course of the study, we also asked people about their experiences with MOUD, and because we think it's important. We know that New Jersey has this incredibly robust MOUD program, but we also wanted to hear from people who are getting the services in the prison, and just to get their perspective on how things are going. So that's what this first slide and theme is about. And out of the 18 people we spoke to, 11 of them had used MOUD before or after release, and they universally reported that it was widely available and accessible. We found that people experienced the medical staff to be supportive of medication use, but there was some variation across prisons and across staff members and correctional support for it, which is not surprising because there's stigma against MOUD everywhere in the community and prisons, so you wouldn't really expect it to be any different there. But many people kind of view MOUD as a crutch or replacing one addiction for another, and so that kind of mentality is prevalent in the justice system, both among corrections officers as well as prisoners themselves. Generally, the people we spoke to mostly said that they had a choice of medications. Usually that would be buprenorphine and naltrexone, with most opting for buprenorphine. And so we did hear some things about their decision-making around that issue. And there's one quote here in the middle on the right here about how I did kind of weigh it out. My fear of Vivitrol, I hear a lot of good about it, but what steered me away from the Vivitrol was I knew people that are on it and they, in their addiction, continue to get high and overdose. So we heard a number of different reasons why people went with buprenorphine, but one of them, like this person is saying, was a fear that that they might still use and that they could overdose, because what happens sometimes is that people will take a larger amount of an opioid like heroin in order to overcome the blocking effect of naltrexone. Most of the people we spoke to recognized the benefits of MOUD initiation, despite having long-term opioid abstinence in most cases while incarcerated. So a lot of people who start MOUD have not taken an opioid for many months or years, but still recognize that, and this is probably a result of the education that they get in the prison, that they're at high risk for adverse outcomes after release. And so that was a good enough reason for them to start treatment. But others also held negative views of MOUD. So the second quote here kind of illustrates that. I'd rather not be dependent on anything in a way. It seems like sometimes it might backfire and you end up being addicted to something else or whatever. I don't want to use that as a crutch. And that's a very similar perspective that you would hear in the community among people who choose not to use MOUD. Another thing that we did hear about from a few people was this issue of diversion, buprenorphine diversion. It's important to recognize there's been some recent research, and one of these is by Monaco, that shows that the motivations to use diverted buprenorphine differ in prisons and in the community. So the general consensus among professionals, or the prevailing thought, is that buprenorphine diversion in the community isn't necessarily a bad thing, because it's most often used, a lot of research has shown that it's most often used for self-treatment. And so it can actually potentially get people to pursue professional treatment if they self-treat a little bit on the street using diverted buprenorphine. But this Monaco study and a couple of other studies done internationally show that buprenorphine diversion, use of diverted buprenorphine is different in the prisons, and typically the most common reason is for its recreational or euphoric effects. And so that presents a real challenge for prison staff trying to minimize diversion while making sure that the people who need this medication and will benefit from it have access to it. But the reason I say all that is because we spoke to a couple people who had some issues around the dose that they received in prison or some negative experiences. Not most people didn't have this issue, but a couple people did bring it up. And this quote from the last quote here kind of illustrates that. They had me up to 4 milligrams, and that's when I started noticing at nighttime, all of a sudden, I'm not sure, maybe if I took twice a day, I might not have had it, because the way the anxiety came, it was always at nighttime. So it might have been when it was wearing off. My body was compensating with making me have anxiety. So typically in the community, people will take buprenorphine twice a day. Sometimes it's once a day, but in the prison, because of this, it's very difficult to administer buprenorphine. It takes a lot of staff. You have to monitor people. And then there's the risk of diversion. It's really feasible only to do it once a day. But then, a consequence of that is that some patients will have these adverse experiences on the medication. Another thing that we talked about or heard about was the transition to community-based care. And few of the people that we spoke to reported difficulties with transitioning to MOUD in the community, although 1 or 2 people out of the 11 who continued in the community did have an issue. But most people had an appointment that was arranged either by prison healthcare staff, like things that Rusty was talking about with the IME, by parole officers, or by reentry organizations and peer navigator programs. And so a number of people did mention the IRTS program and how that was something that was helpful in linking them to care in the community. Another thing we learned is that the prison social work stuff does help people apply for Medicaid and other benefits before release. And everyone we spoke to had a meeting, it seems to happen about 6 months before release, where they applied for Medicaid and other benefits. But a couple of people did have challenges with their enrollment by the time they came home. And again, we haven't talked to enough people to say that we know what all the issues are, but it seems like the most common are if somebody was duly eligible for Medicare and Medicaid, there were some issues with getting the application approved before release. So that took a little bit of effort in the community to get their Medicaid activated again. The other thing was if someone was released to a different county than the one that they applied for Medicaid in while they were incarcerated, sometimes there were issues with eligibility related to that, because they would, the county office would say you apply for in such and such county, and so you have to go follow up with them, which of course it can be quite challenging for someone just coming out of prison without transportation. One thing that people did note is that even though they applied and often had Medicaid at the time of release, they often didn't have a Medicaid card, which created some issues when trying to access care or medication. And so there's a quote on the right, the 4th one down, showing that they never gave me a card. I usually have to show my Social Security and stuff because they never gave me a card. Every time I went to the appointment so far, it's been a little tough because I don't have an ID card. I missed a couple of doctor's appointments. So sometimes that was a barrier, not having the card. Another thing that came up frequently was the importance of having a cell phone after release. And there are some programs with the DOC that provide cell phones to people being released, especially the IRTS program I know gives people a cell phone who need one. But that became very important, especially with COVID, where so much is done remotely and over the phone. And so people who didn't have one had some issues with accessing care, and not just healthcare, but also other benefits, because some social services offices are also working remotely. And then so we also heard from some people about some of their general needs and structural barriers to recovery and reentry. And those of you who work in this space won't be surprised at all by any of these, because this is a long-standing problem, and these are structural issues that are not really easy to address without larger reforms, rather than some of the programs that we're talking about. And so the greatest needs we heard about were permanent housing. Folks did have temporary housing often set up for them after prison release. There's, although there were, some difficulties with that as well. But finding a permanent place to stay was a challenge. Stable employment, transportation, identification, and again, the phones. And so folks did talk about how the community organizations that provide case management and other supports helped address these needs. but they couldn't always meet the demand. And that was especially true during that very large release where 2,000 or so people were released in November 2020. Okay, so some of the conclusions from this qualitative work so far. Most people who have OUD recognize the benefits of MOUD initiation before release, but there are still some who hold these negative views of MOUD. And so potentially some additional education could increase people's understanding of the benefits of MOUD and also medication options. And then there's this issue around diversion. It's a challenging and complicated one that Rusty can speak to quite a bit. But unfortunately, the need to balance healthcare with diversion means that some patients are probably not going to be fully satisfied with the medication treatment they get in prison. Providing Medicaid cards is important after release to ensure continuity of care. And then again, just reiterating some of these major challenges that are that people identified during reentry, which are important to address alongside addressing the substance use disorder itself. Some of the limitations, of course, are those that are inherent with qualitative research. It's a small, convenient sample, also recruited from a single agency, and the views that I just talked about are only those of the released prisoners who we spoke to, and don't include views of service providers or correctional staff. All right, so just to kind of wrap up, I'm going to talk a little bit about some of the ongoing work that Steve Crystal, Rusty Reeves, and I and other collaborators are now working on. And one of these is an in-progress study that's looking at post-release outcomes of prison-based treatment and interventions for substance use disorder. And so one of the aims of this study is to look at, among inmates with substance use disorders, what are the predictors of fatal and non-fatal overdose risk after release, and also predictors of substance use related hospitalizations and emergency department visits, as well as trying to identify some of the demographic and clinical risk factors for those outcomes. And then the second aim with that study is to take a deeper dive, looking specifically at some of the prison-based and other related interventions we spoke about, like medications initiated in prison and the Peer Navigator program, and looking at the association of participation in those programs and post-release outcomes, again, overdose, hospitalization, and recidivism. And so, as Rusty was saying before, there isn't a ton of research on this. There have been some trials like that being done by Schwartz and colleagues, which have shown that haven't found a particularly strong or any effect of some of these interventions on overdose and other outcomes long-term after release. And so we want to extend that by taking advantage of the fact that New Jersey has such a large program, and there's been several thousand people who have been released on MOUD and have participated in peer navigation. And so that gives us enough power to look at these issues in large usual care populations and kind of go beyond what's been done so far with randomized trials. And so the way that we're accomplishing that is using all administrative data from a couple of state agencies and then a few other data sources. So so far we've been working with data from the Department of Corrections and from University Correctional Healthcare from Rusty, which contains demographic information, criminal history, as well as medical healthcare services received and diagnoses while the person was incarcerated, as well, and the services that they received while incarcerated. And then we're also working with Department of Health all-payer hospital discharge data, which captures all of the hospitalizations in the emergency department and inpatient units throughout the state of New Jersey, regardless of payer. And so that'll allow us to look at overdose and other opioid-related or drug-related events after release. Third, shown here in the middle, we're working with Department of Health death records, which show date and cause of death And so linking all three of these data sets will allow us to look generally at post-release outcomes and predictors of those outcomes, and then also specifically at the effect of the interventions we talked about. And again, because it is such a large sample size, we can apply some statistical methodology to try to rule out as much of the confounding that Rusty talked about. And then on the right side here, we're working on incorporating additional data sets, if possible, if we can, such as Medicaid and evaluation data from the IRTS program. All right, and so then I'll also turn it back to you, Rusty, just to talk about this other study that's related to this work.
I'll do this briefly because we want to take some questions. I'm also participating in a NYU-sponsored, NIDA-funded retention study of Sublocade and Vivitrol, both injectable forms of buprenorphine and naltrexone, respectively. This is a multi-site, nationwide study. Josh Lee at NYU is the PI. I'm the site PI at the prison system. These will be transitioning inmates to the community on these medications. And my counterpart, where they'll receive follow-up, is Dr. Amasika Nyaku and her supervisors, Aaron Zerbo, in New Jersey Medical School. So I've received the sub-award for that, and that's just now starting. So ready to take questions, Peter.
Great. So we only have a short time for questions, but oh, this is perfect. Now we can see everybody. So if you'd like to ask a question, feel free to either unmute yourself or put something in the chat so that we know that you'd like to ask a question. Who wants to jump in? I'll give about 10 seconds and then I'll ask a question myself if we don't have a volunteer. The usual politeness here.
I personally don't have a question. I just wanted to say that it's a pleasure. I represent the IME, Addictions Access.
Great.
It's a pleasure working along with Dr. Reeves and the IRTS program. And we look forward to working along with Peter as well. So just good to work along with everyone. Thank you.
Yeah. Hi, Donovan. Donovan was one of the people I was working with that was working with me on providing the data on the follow-up and giving, helping me along with this. So Donovan in the IME, and I know everybody in the IRTS. I don't know everybody, but I know the folks in those, and everybody was very helpful in making this happen. And I think everybody is doing their best to get people appointments to follow up in this. They're working hard on that.
Great. Who else would like to jump in? We have a special opportunity here with such knowledgeable people. So while people are sort of collecting themselves, Rusty, can you sort of comment on, we've gone a long way. What kinds of things do you think are the next steps? What are the things that we need to think about to make reentry more robust?
Well, I think our study, and you as the PI, that study, we're going to find out more broadly what we're doing is working, and not just in first appointment attendance, but beyond.
Right.
So I think what you're doing is going to answer some of these questions. Likewise, the study that I'm participating in is Sublocade versus Vivitrol.
Yep.
I'm particularly interested, given what my concerns about that. I do think buprenorphine in particular works. People like it. It's not an antagonist. You've got heroin, then you got methadone, and then you got buprenorphine. They're all three agonists with less euphoric effect as you go down to buprenorphine. People vote for it when they have their choice, but they stop it. And intuitively, it makes sense that Sublocade, somebody gets an injection, they'll be on it, so they can't divert it unless they cut it out of their, do a Hannibal Lecter on themselves. And I don't think that's happened very often. It's under their skin. And so, they've got it and it will be protective. It's hugely expensive right now. It's just outrageous. and it hasn't demonstrated superiority yet to sublingual buprenorphine. But I'm eager to see if Sublocade may have a future in helping with compliance. And then there's all sorts of other ancillary social service needs that people might require individually. But from my as like a pure doctor, pharmacology, I'm interested in getting a sure thing into people and seeing if that works.
That is so important. And it is shocking. I mean, it's just like one little piece of the whole craziness that we have with the pharmaceutical companies in this country that just price new, while they're on patent, they price new treatments at just these sort of astronomical levels. And I'm hoping that there will be a breakthrough and maybe competitors in that space. So that piece is important, and I think the issue of the kind of mixed methods approach that Peter has been taking, where we're really combining the rigorous data analysis with the direct feedback from participants and also from folks in the service delivery system, from navigators. I think all of this kind of mixed method approach is going to be very powerful. And I've been certainly very happy to lately to hear from some of our colleagues in the national advocacy world, legal advocacy world, that there's litigation going on across the country about access to MOUD for imprisoned people. And of course, this extends not only from the prisons to the jails, which is a complicated problem in New Jersey with all these different sheriffs, different facilities. But there has been litigation. I think the litigation, New Jersey, I think avoided litigation by being so proactive. And I think, as Peter was suggesting, there might be a possibility for some transformational change across the country. And in combination with some of the sentencing reforms and other things, we could actually start to see some movement away from all of the harms that mass incarceration has created. We're still open for any final question.
I have a question, Steve.
Okay.
Hi, Rusty and Peter. It's Sharonese Todd. Thank you very much. It was very enlightening and, as Rusty says, tantalizing. And I wonder about the Medicaid access, not just for people who are using MOUD in or out of incarcerated places, but in general, Rusty, what would you say the health status is of most people in prisons, and how do they benefit from Medicaid? Are you making the same efforts with that for everyone that's being released in terms of that connection to insurance?
Okay, let me see if I can answer your question properly. I think we know that it's well known that inmates overall have all sorts of medical problems, more so than the average person in the community, particularly as they get older. I think it's been very helpful for New Jersey to have adopted Medicaid reform, like a bunch of other states have done. It's been essential, for example, for them to get Suboxone when they leave, as well as any other prescriptions. We haven't studied what people do with it in the community. That's something what Dr. Crystal is going to be looking at, the Medicaid expenses. The enrollment in Medicaid or the renewal of Medicaid is done by the Department of Corrections. It's not done by Rutgers UCHC. So we have nothing to do with issues of getting a card, of being duly enrolled. It's just not our bailiwick. And so you'd have to direct that kind of question to the Department of Corrections and their social service workers who are working on getting people enrolled in that.
Thank you.
All right, so we are out of time. We want to respect everybody's schedules. And it's really great to see this great turnout, and we hope to hear from some of you as we go forward. So thanks to Rusty and to Peter and to Georgette for organizing all of this. Georgette asked me to remind you that there will be a quick poll. So please participate in the poll so that we have data, outcomes data on ourselves. And thank you, and we hope to see you at future webinars.
Thank you.
Thank you.
I'm submitting it myself.